everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Richard Rosedale, and he's going to talk about 2 papers he published on extremity pain of spinal source and its indicators. Richard has been a PT since 1992, a member of the McKenzie Institute teaching faculty since 2003, and in 2018, Richard was appointed as the International Director of Education and the Diploma Coordinator for the McKenzie Institute International. I hope you enjoyed the show. Hi Richard, welcome to PT Pro Talk. How are you today?
Hello, Mariana. I'm good today, thank you.
Awesome. So I'm excited to talk about the last 2 papers you published on spinal extremity differentiation. So before we jump right in, just tell us a little bit about yourself, your career. How did you get to where you are right now?
Okay, so I'm a physiotherapist from just outside London, Ontario. I've been a physio for nearly 30 years. I trained in England, Guy's Hospital, and soon after which I emigrated to Canada. I started training in the McKenzie system, and that became my kind of focus, clinical focus, and eventually my research focus. And I came on through the system and started teaching, and more recently became the Director of Education for the McKenzie Institute. So I'm still a practicing clinician. I am Director of Education. I have been involved in research now for over a decade. And that's it, I guess. And here I am.
The short version.
That's the short version, yes. For listeners.
So let's talk about the last 2 papers that you just published. So would you tell us a little bit about the Expo Study and its findings?
Yeah, so this was a study which in my mind was kind of a long time coming. So people supposedly screen the spine when they have an extremity patient, but there doesn't seem to be any kind of data to tell people, is that a frequent thing that people coming with extremity pain where it's supposedly coming from the spine? Is it a rare thing? What's the kind of prevalence like? So that was the first question, was about sort of prevalence of this situation where somebody comes in with isolated extremity pain. They're convinced it's coming from the extremity, or their physician is. And this was kind of one of the inclusion criteria. So they come in with this pain, and we use, as practitioners using the McKenzie method, we go through a systematic way to sort of screen the spine. And if the patient's symptoms change as we move the spine around, and then we move on and look at the spine and treat the spine. If things don't change, then we basically go on and treat the extremity. So we wanted to find out, when you look at the knee or the ankle or the elbow or the shoulder, what sort of percentage of patients are we looking at here? Because we could all recall, I remember that great patient I saw, a month ago, and she came in with elbow pain, and we moved her neck around, she got better. How commonly does that happen? And we have this recall bias, of course, where we think it happens very, very commonly, but we're not really sure because we don't sort of keep data. So we had 2 centers in Canada, 1 in the US and 1 in New Zealand. So 4 clinicians, consecutive patients coming in with isolated extremity pain that were recruited. And then we went through the MDT process of screening those patients to see if the problem was coming from the spine, from the thoracic spine or from the lumbar spine. If we found they were coming, the problem was changed as we moved the spine around, then they were treated by doing repeated movements with the spine. If not, then they were classified and treated as an extremity problem. And then we followed those patients. We did compare the groups, not that it was that wasn't the main purpose, but we were comparing the groups really to give some verification for the fact that this, if this was really a problem coming from the spine, then we would expect it to be at least as good as, in terms of outcome, those where we treated the extremity. If we'd completely got it wrong, then we wouldn't expect a good outcome if we were treating the spine and it was an extremity problem, we would expect a poorer outcome. So we wanted to do that comparison just to kind of verify that we were likely sort of on track in terms of our finding the proportions. So that was the basis.
Yeah, I think that's very interesting because I think most times it's kind of intuitive that we go and screen the spine to clear the spine first, but I don't think there were any systematic studies or anything that would give us the numbers. So I think it was quite surprising, the numbers.
Yeah, the numbers were surprising, yeah.
Yeah, so that was going to be my next question. Were the numbers on that study surprising, and were the results similar to what you see in clinical practice?
I think for some of the results, it was quite similar to what we expected, but for some of the others in different areas of the extremity, it was a little bit more than we actually expected. So it was quite interesting to see those numbers coming, especially for someone like the hip. 70% appeared to be influenced and treated with spinal movements, and that was regardless of the location. So we expected to have more patients with kind of buttock pain to be from the spine, a little less with maybe lateral pain, and less with more groin pain. But the three were fairly equal when we actually broke that down. That's not in the study, but when we looked at those different locations, it was fairly equal. So that was kind of interesting too. I think most people would expect the shoulder to be higher in terms of close to 50%. Maybe some people expected the knee to be higher. It came out like 25%, and maybe people thought, I expected more knee patients to be referred. But this was knee patients without the obvious kind of referral down the back of the thigh and accompanying pain, which is more obviously spinal. These weren't patients that were obviously spinal. Like, for example, the shoulder ones didn't have, pain in their upper traps as well, or the scapular pain as well, which would have been too obvious. It was isolated kind of extremity pain. So, yeah, so some of the results kind of were a little bit surprising. Some of them, I talked to people afterwards, and some exchanges afterwards, and some people said, "Oh, yeah, that's kind of what we expected." It kind of verified what we thought, but there's no doubt it needed to be verified, because you can only go around so long and say, "Oh, yes, we see lots of extremity patients with a problem. We treat the spine, they get better." But do we really? I mean, what are the proportions? So we needed to sort of document that. And this was the first stage of doing that. And hopefully it's not the last time it's done. This was just to put that information out there, and hopefully people will see it and say, "Oh, okay, that's interesting. Let's see if we can replicate that." Either using, the McKenzie approach, or using another approach to see if the numbers are the same. So.
I thought that the arm and forearm, the number was really high, 83%. So, yeah. I mean, I think that's kind of expected, but it's just nice to see like the 83%. That's like a huge number.
That's fine. So yeah, between the joints, both in the upper and lower extremity, the numbers were high. So that's a good clue for people if people are coming in with pain between joints. Really, we should sort of suspect the spines.
The same thing with the thigh and leg. That was 72%. That also a high number.
Mm-hmm. Yeah, and I think that's probably not that unexpected. People come in with pain in their hamstring, and most clinicians that are keyed in would think, let's really check out the lumbar spine. I mean, I think the message from this, sort of going back to the previous point of saying this is something we do day in and day out, is that message that do we do it properly, and do we do it adequately? And even with this study, have we done it adequately? What is a good screening of the spine? How can we say we've ruled out the spine? And so this is what we want to start a kind of conversation on and get people kind of thinking about, because it's something people do day in and day out, many times a day, but really with lots of assumptions on that. Oh, yes, patients, then their neck is moving well, it's not coming from the neck. Or they've got no concurrent neck pain, or they haven't had a history of neck pain, and so that's not the problem. But are we sure about that?
Yes, and in your opinion, is the screening of the spine in the presence of extremity pain a normal practice between PTs?
I I think if you ask most PTs, chiropractors, they would say, yes, of course we screen the spine. The question is, how do they screen the spine? And, do we have any consensus on what is an appropriate level of screening? And I think if you look, if you look in the research and look at some of the criteria for some extremity studies in terms of, okay, we kind of screened the spine, how did they do it? They might have looked at range of motion loss. They might have asked if they have concurrent pain. Sometimes they may have gone in there and sort of mobilized, done some manual therapy on the spine, and there's no change on the extremity. I think it's not uncommon for people to kind of take an extremity baseline, do something to the spine, then recheck the baseline. Again, it's just, how thoroughly do you do that? Is the question.
And have a way of doing that systematically. Like, I know the McKenzie has a very systematic way of assessment. So then how about the other techniques that the PTs use? Because I think it's really hard to have the same standard of screening.
Yeah, that's right. I mean, maybe other approaches, do that in a really systematic way as well. And I say it would be nice if they went ahead and kind of tested that and see if they came up with the same kind of numbers. But I think, I think many of us have come a long way with this, sort of over the years. And, the problem is it's kind of patient presents with this kind of, it seems so obvious that it's an extremity problem. Their pain is very isolated. They're restricted in their extremity movement. Functionally, they get pain when they move and do stuff with the extremity. And so with that kind of scenario, it's like, it can't be a spine. It just can't be a spine. It must be the extremity. So the screening is often very quick, I think. And so that's kind of the problem. It's that, okay, it's that recognition of, yes, it looks like an extremity, but really is it the case? And what's the appropriate screening to make sure?
Yeah, because as you were saying, for example, the knee, that was 25%. The pain was very isolated on the knee. So still 1 in each 4 is coming from the spine. Is still a big number that's worth checking, even that you don't have any other clues saying, at first at least, that it's coming from the spine. It looks like the knee. So I think it's important to identify these factors, right?
Yeah, it is. And the selling point of it is, look, if it is the spine, for our study, nearly all those that it was coming from the spine had a directional preference. So if it is the spine, the implications are the patients can do an exercise themselves, going to probably turn this problem around quite quickly. And that's kind of was shown with the outcome. So that's kind of the selling thing. Even if it's just a quarter of the patients, like in the knee, it's worth just capturing those quarter, because their response is going to be quite quick. The solution is going to be simple, and the patient's going to be able to do it primarily by themselves with simple exercises. So, if those patients are there with that problem, then it's surely worth spending a little bit of time checking that possibility out.
Absolutely. And then you just published another study now in January 2022 that is exploring indicators of extremity pain of spinal SARS as identified by MDT. So what were the indicators found?
Yes, so within that same study, we also looked at potentially what factors were associated with those problems that were ultimately seen to be coming from the spine and treated with spinal intervention. So we kind of put some various factors down, and then they were analysed, and the association was looked at. So then we found that we had a couple of indicators from the history and sort of 3 indicators from the examination. So kind of 5 indicators statistically seemed to come out that were worth taking note of. So the 2 from the history were presence of paresthesia, which maybe is an obvious one, but also from the better worse section, or aggravating sort of easing section. Were the symptoms affected by bending of the spine, turning of the spine, when somebody was just still, or when they were just sitting. So were the symptoms affected by that from the history? So you got those two factors from the history. Then from the examination, you have were the symptoms influenced when they changed their sitting posture from a sort of slouch position to an erect position and kind of back again. Was there a restriction of spinal movement? And was there no restriction of extremity movement? So those were kind of the 5 factors. And from that, if 2 were positive, 2 indicators were positive, that had fairly good values in terms of sensitivity and specificity. Better on the specificity front. So if 2 or more were positive, it was looking pretty likely that may be the spine, and that may give people, because obviously that's before the repeated movement section of our examination, so that might give people some more incentive to kind of really search the spine a little bit more if it wasn't obvious as soon as we started moving around there wasn't directional preference. Because if you have those factors, many of those people are obviously going to show changes quite quickly when you move the spine around in that repeated movement section of the examination. But if they didn't, then it'd be worth exploring that, taking your time to explore that more, because there will be a higher chance that would be. So we felt that people did need a little bit more guidance. It's one thing knowing that the prevalence is quite high, but it's another thing saying, well, how much time do I spend on this? Do I spend 2 minutes? Do I spend the next first 2 sessions checking out the spine? So this gives people a little bit of guidance in terms of, okay, there are no, indicators from the history or exam. I can be fairly cursory with the spine, or no, there are a significant number. We really need to be very thorough here because this is looking like a spinal problem. And then that gives people guidance in terms of how much time to spend on exploring end range of the lumbar spine and the cervical and thoracic spine. Do we just do extension? Do we do extension flexion? Do we do lateral? Do we add overpressure? And so on and so forth. So hopefully that's helpful for people going forward.
Yeah, absolutely. To give it more efficient, so you already know you had some clues on the history taking, so you already know that you should take some time doing the physical exam and going from there. So I think that's very helpful. And then how can we make these better known by other PTs? Because it's so important, right, to spread the word about the high incidence of extremity pain from spinal source. We learned so many techniques in college and not as much about clinical reasoning. So how can we bring this information to other healthcare providers and make screening of the spine a routine procedure in the presence of extremity pain, especially when you have these indicators that you just talked about that you found on the last paper?
Yeah. So, I guess this is one way by talking about it and sort of getting the word out there, and on, social media as well, people talking about it and circulating about the study. But of course, obviously the first step is to get the studies published, which have been published, and you hope people, read the journals and read the articles. I think the problem is once people think that an article is about the McKenzie method, especially if that's in the title. And for the second paper, we kind of resisted that being in the title, but we had to put it in there in the end. Some people will automatically not read that study. And so then that really limits people that are exposed to that information. And so, yes, it's great for people already engaged with the McKenzie system. They read the study and it kind of supports what they already thought, and they have this extra bit of information which they can use, and that's great. But getting the word out there to non-McKenzie clinicians is a challenge, and ultimately, we can try the best we can, but we can't force people to take this on board. We can't force people to read studies. So, I don't know if. Hopefully, again, there are people out there that will read it, researchers out there that will read it, clinicians that will say, yeah, that's interesting. They may not put any credibility to it because it's associated with the McKenzie method, but they may say, okay, well, this is worth exploring in terms of our approach. And let's do this, study from a manual therapy perspective or whatever, just to see what the numbers are. And that will be really interesting, because I do feel, obviously it's about the patient, what it comes down to. So there are people with extremity pain out there that get treated, their extremity gets treated, and that's not perhaps going to get as good outcome as if their spine was treated, if that's where the problem is seen to be coming from. So, it's about getting sort of good outcomes for the patient, and if we can spread the word and get other people to think about this, then I think it's it. But, the other thing is just to think about it. You're a clinician, you've been out there for 20 years and you've been treating all sorts of spinal extremity patients. You've got in the mode of feeling pretty confident about screening the spine, and you may just be convinced that just looking at range of motion or asking about the spinal history is enough. And so when you take this on board, this new information, it's kind of telling, well, maybe there was a few patients you missed out there over the last 20 years, a few, hundreds of patients you missed out there, and you were treating their extremities. You couldn't get that problem better because that wasn't where what needed to be treated. And so that also takes a bit of humility to go back and say, now I know that I have to be a little bit more thorough with this. But in terms of, I think it's if anyone's got any ideas, it's a real dilemma. You put the papers out there, you put them in journals which you assume many clinicians look at and read, but I don't know how you get people to change their practice. We know that any research takes a long time for practice to change, so our expectations are quite low. But you do what you can.
No, I'm sad to hear that. But because paresthesia is something that's very common and most people relate to spinal SARS. But the other indicators, I think they were very interesting because it involves position, sitting, turning spine, bending the spine, and having that related with extremity pain. Because I remember I used to do a lot of manual therapy. In Brazil, I could do osteopathic that we can do in the US. I'm not sure in Canada, but so I used to do a lot of manual therapy, and I don't remember never being mentioned about positioning affecting symptoms, distal symptoms. So I think that's a very different reasoning, clinical reasoning that's very interesting and very related to the extremity pain. So it would be great if other clinicians would be able to put that in their assessment as well and just check and it's not something that MDT is just MDT exclusive. It's something super simple that it could be included in other techniques or methods like assessment forms and be checked for PTs. But I think the problem is I don't remember seeing that before I start doing the McKenzie courses.
Yeah, I think to the first point, it is something that is easily integrated into anyone's assessment. The presence of paresthesia in the history, everyone would ask about that. Everyone would look at restriction of spinal movement. Everyone would look at, the extremity and see if there's a restriction of spinal movement. So you've got three things that everybody does. Okay?
Yeah.
Then you've got the questions in the better, worse section, which, some people may touch on if they're not MDT clinicians, but it takes another minute to ask about those things. The one thing I think is a little bit foreign to people not using the McKenzie method is, does the extremity pain change as somebody changes their posture, which is in fact a dead easy thing to do. It takes like 30 seconds to a minute to do it, and again can really easily be integrated into anyone's exam. So again, we try to look at this as not a paper which just has implications for MDT clinicians, but should have implications for everybody out there. We just need to get the word out, and people should try to integrate these things and see what they find. So we'll see.
Yeah, it would be interesting if people would start using that in their daily practice. And as you said, then compare with their techniques, because if they find that it's coming from the spine, whatever they are doing, is that affecting and improving the distal symptoms? That would be other thing that would be very interesting to find out.
Yeah. The other thing which it was kind of interesting about the what we found with the patients is that we didn't find people had one pain and two sources. So if somebody came in with elbow pain, it was either going to be their elbow or it was going to be coming from their cervical thoracic spine. It wouldn't be. It's a little bit of influence of the neck, and then the rest is coming from the elbow. People can have two separate problems. They did in the study. So we had 369 patients in the study. Some people had separate problems. So you move the neck around, the neck felt better, moved better, but the elbow didn't change. So there were two separate things, and they were categorized for their extremity pains and extremity problem. But we didn't see patients where we started to move their spine around. They were like 30% better, 50% better in the elbow, and then the rest of the problem was an elbow problem. And I think this is another kind of thought out there which perhaps interferes with people being thorough with the spine. They may start to move the spine around, exercise the spine, manual therapy on the spine, and find there's some change. And then they also concurrently, move on and treat the elbow, the extremity at the same time, or give up on the spine and then move on to the elbow. And from our study, it looks like that you shouldn't have to do that. If you're going to get that sort of change, you're convinced, you've got your baselines and you get that change, and the change is convincing to you and to the patient, then you should plow on. And because really you're probably going to get, good resolution just with treating the spine for extremity, and you shouldn't have to treat the extremity problem as well. So we didn't get the sense that it was this, you have to treat, the spine, and you have to treat the extremity, and you have to treat everything in between. So life can be much simpler than that.
Yes, and I think sometimes can be confusing. We don't find the full resolution of the symptoms just doing spine. Sometimes it's tempting to go to the extremity to see if you can get a better result.
The other thing you have to take into account is, of course, the patient and their sort of expectations and their outlook and their kind of attitude as well. So you obviously have to be communicating well with the patient, explaining exactly what you're doing, sort of bringing them along with you. Sometimes you get the sense that they're getting, you're looking at the spine and they're coming with I'll use the elbow again, their elbow problem, and you're getting the sense they're getting a little bit fed up because, they're not convinced at all. And so that may be the time you say, okay, let's check out your elbow and we'll start to, and so maybe you move on and maybe you do find a response in the elbow and you sort of quickly move to that, and the patient's kind of guided you there. But I think we have to be aware of other factors, and central to which is the patient and their response, attitude, expectations. And we have to be continually communicating with the patient and bring them along with us. If we can get that dramatic change in the first session and we move their neck around and their elbow feeling significantly better, then most patients are totally bought in right from the start. But if we can't, if we're getting this sort of subtle change, we need to explain exactly what we're doing to the patient, why we're doing what we're doing. Otherwise, they're probably not going to come back again. Their expectations are not going to be met. Their expectations coming to see you is you're going to treat their elbow. If you don't touch their elbow and move their elbow around other than getting baselines, they're not satisfied. So you need to take that into account as well. And the other thing, of course, is we're never just treating a body part. We're always thinking about the other aspects which influence patients' experience in terms of pain and can obviously influence their outcome as well. So we need to take all those things into account. And I know in a study where we're talking about body parts, we're talking about is it an extremity or is it the spine? People assume that we're not taking into account all these other factors which can influence the patient. Obviously, taking those things as well.
Yeah. And I'm just curious to ask you one more thing about the study, that the results on the patients that had extremity pain coming from the spine were better than the ones that were just coming from the spine. So We know that is because probably they had a higher incidence of derangements on the spine, right? And then on the extremities, why did you think that the results were not as quick? Because you didn't have as many derangements, or it wasn't just responding as quickly?
So yes, generally that the spinal patients were by far dominated by, with having a directional preference, and that would be, if we break down, we know from other studies, prevalence-wise, on average, we see about 40% of extremity problems being derangements, and then we've got a whole mix of other stuff in there that is not going to respond so quickly. Like, contractile dysfunction, for example, is going to be a much slower, kind of steadier response. So we're comparing a group of people with nearly all of them had directional preference compared to another group which, maybe half of that, up to half of them had directional preference, and then you had a whole mix of other things. So it's not a fair comparison in that way. But as I say, it's done just to give kind of credibility in a way to say, okay, if we'd have done that comparison and found the extremity patients did a whole lot better than the spinal ones, then we're really questioning, did we really get that right? Were these really a group of patients where the problem's coming from the spine? So, it wasn't a randomized controlled trial. It wasn't a fair comparison. So hopefully, again, in another type of study, there could be some randomization involved, and you could have a much kind of fairer comparison, and to be really clear about whether the patients designated as a spinal problem did really get better than those that were designated as an extremity problem. So we'd need another study design.
Yeah, it makes sense. And let's transition to our final questions. Before we do that, do you want to mention anything else about the papers?
I think that really they speak for themselves. They're fairly, I would obviously encourage people to read the papers. They're fairly simple sort of studies, papers to read. And but there are some sort of, details which are important. And I think probably the most important thing to know is that these are the first studies which have been done kind of on this area, and so it's not it's not cut in stone that these are the prevalences and these are the indicators. So it's a starting point. It's something for us to kind of say, okay, if you're a clinician and you're finding that 50% of your shoulders seem to be spinal, then maybe that's good, because it tells you, okay, that's kind of aligned with what the study said, so that's kind of helpful. But if you find that only 25% of your shoulders, maybe it's because of your setting. You're in a different setting from the setting we were in as clinicians doing the study. Maybe there are other reasons as well. So if this is replicated in different settings, with different populations, with different clinicians, then we get a better idea. So it's just really a sort of, this is, of course, I'm enthusiastic about it, and I think people should take note of these studies, but it's just a precautionary sort of note that these are not definitive yet, and hopefully they're the starting point for us to become more definitive.
Absolutely. Let's hope that another ones are going to come after that one. And what is your favorite resource of information? Do you have any books or specific papers, studies that you like?
So what I've been doing for a couple of decades is I've been noting down about, it's built up. So some of the main journals that published research that sort of would be relevant and interesting to us. So I kind of note down the journals, and I check every new edition of those journals. So that's my main kind of source of kind of input in terms of what's happening in the research, and that kind of keeps me up to date. More recently, I probably, I'm on social media a little bit, so Twitter, and there are articles which circulate on those, and people give links, and that's really good because sometimes it's in journals. You can't search all the journals, so sometimes you get the odd article in a journal which doesn't normally publish perhaps so many relevant articles for us, and so that can be drawn from that, and so that's really helpful as well. But I think my approach over the years has been quite systematic, and checking, these regular journals, every month, or 3 or 4 times a year, however much I published, and then checking through all the articles, and then accessing those articles that are relevant, and put them in your own kind of library. So if something comes up, like a different condition, or a test, or a problem that you haven't seen before, then you can access your own library and kind of check through the articles. Or if there's some discussion comes up, you can check back through the articles you've stored over the years. So that's what I've done over the years, and I think it's been useful for me to keep abreast of what's happening in terms of the literature, and I would recommend it as something people should do. I just have a little card, and I just tick off, literally, just because I've always done that. I mean, I guess I should put it on my computer, but I just tick off a little card every month. This journal I've checked.
Yeah, that's great. That's great. And what would be the best advice you give to the clinicians that are starting their careers?
Oh, to do that. to get a little card and to write down the journals and stick off the journal. So, that would be one thing in terms of, but that's not all about keeping up to date with the literature. So, advice would be to, the challenge is there are so many different philosophies and approaches to musculoskeletal care. As a student coming out, you're trying to kind of understand these different approaches. You're trying to sort of weigh them up, and you're trying to make a decision in terms of, which way to go in terms of your practice. And that's really challenging. My preference is people should do that, should try to understand different approaches, different philosophies, and at some point they should make a decision about which kind of approach they want to use, and then they should put their efforts, invest their time and energy into that approach, and be good at that particular approach. Now, depending on the sort of the culture of sort of clinical practice where people are, sometimes that's difficult. Many cultures, everyone mixes everything together, and they do a little bit of everything, and that's kind of tough to really then evaluate what you're doing in terms of your patients. If your patients get better, you're not really sure what you did that helped them, because you've done a little bit of manual therapy, you've done some modalities, you've given them some stretches, you've made, you've given some exercises, what helped. And so for your own kind of learning, I think it's also good to be kind of quite selective in terms of what you give to people, so you're able to evaluate that. And then obviously you're doing that in conjunction with, drawing from the literature, and deciding which is the best way forward. But I think at some point, my feeling is that because I needed some structure and some framework to work within, people that need that, I think should look at approaches that provide that. If people can get by with doing lots of different things, if they feel satisfied with that, they feel the patients appreciate that, get better with that, and it's in concordance with the evidence, then obviously that's a personal choice. But I feel as though that people should weigh up these different approaches and decide kind of which way they're going to go with that. It's a bit overwhelming.
Yeah, I agree, because then you do a lot of different things and you don't even know what is the one that is really helping and that you should focus on, instead of giving 15 exercises homework, like usually they do in traditional PT clinics. It is overwhelming.
Yeah, it is. I mean, people need to be critical as well, of course, of different things they hear. People are going to go on many postgraduate courses when they come out of school, so they need to I'm not going to say not believe everybody what they say, but have a healthy cynicism and check it out themselves. And I know when I went on my first McKenzie course back in the UK, I came back from that, and because they'd said that there was a good degree of support in the McKenzie system. This was 30 years ago, and I came back and there wasn't really much support at all. So I remember doing a presentation where I was really critical the course I went on. And so I would encourage people to do that. I mean, there's a point where you have to accept that not any approach has a great wealth of evidence supporting it. And when you look in the literature, much comes out on a fairly equal footing. But there are certainly some things out there which don't have less support. People should be sort of moving away from, and I think awareness of that through reading the literature and being really thoughtful about clinical practice is important.
Yes. And final question, what personal qualities or abilities are important to become a successful professional?
I think the first thing is really you need to care about your patients. And I think everything will follow from that. If you really care deeply about your patients and understanding their perspective and their goals and their expectations, and trying to do your best for them, then all the other stuff should follow. Because, of course, if you want to do your best for the patient, then, you want to make sure that your approach is kind of in line with what the evidence sort of tells us. You need to make sure that the patient is involved in that and engaged in that. So I think that's probably the most important thing. I mean, along with that becomes the sort of, I think there should be a sort of humility, which means that, you're not thinking yourself as a great, therapist that kind of knows it all, and you're open to, to change and to develop and learn. And I think that's really, really important. But again, that comes back, you're doing all those things, not for your, credibility or your status. You're doing that so you can provide better care for your patients. But I think my assumption would be that that's why many people come into, to become conservative care clinicians, physios and chiropractors, because they want to help people. And, if you come in for the money, then you're probably going to be disappointed anyway. But
that's the final goal. Find ways to improve the care.
That's right. That should be the focus.
Yes, absolutely. Richard, if people want to learn more about you, your work, or even contact you, how they can find you?
More about my work. I mean, all the studies I've been involved in will be sort of published on the McKenzie Institute sort of reference list. And I mean, there are many more people out there that have published much better studies than I have, and so that's a great resource for the McKenzie material generally. And so they can contact me. My contact is on the McKenzie Institute Canada and McKenzie Institute International website, so people can contact me if they like. I'm just one of the instructors. We have nearly hundreds internationally, so I'd encourage people to be engaged with their own branch wherever they are, and try to see where courses are coming up. If they've gone through the courses, then certainly it's great to keep in contact with other faculty and get to know other people practicing MDT. So.
Yes, absolutely. I really appreciate you taking the time and sharing all your knowledge with us and all your effort that you put on your work, your papers, your research. So thank you so much for what you do for our profession. And I appreciate you taking the time to be here with us today.
Well, thanks very much for asking me, and it's been a pleasure meeting you. So thank you.